Welcome to the 2019 Collaborative Protocol Update for Advanced Providers. My name is Ann Smith, and I am the North Country EMS Program Agency Director and your presenter for this update. This presentation is a collaborative effort between the following program agencies: Midstate, Finger Lakes, Central New York, North Country, and Susquehanna. The 2019 protocols incorporate the CFR level of care and have been made consistent with the updated New York State BLS protocols. Upon completion of this PowerPoint, you will need to log into the online CME site and take the 2019 protocol update test to verify that you have completed the update. All AEMT, critical care, and paramedics need to complete this update and should have already completed the New York State BLS protocol update. The format of the collaborative protocols have not changed with the exception of the added level of care. Bullets are still used to outline treatment options. Many processes are not sequential and should be performed as most appropriate for patient presentation, using good clinical judgment. Regional policies may accompany these protocols, and if you have any questions, please reach out to your regional program agency director. You will notice a star after some treatment options indicating, if equipped and trained, this means that you have been regionally approved and trained for said intervention. Also remember, good BLS before ALS. Human development is a continuum, and it's very difficult to determine the precise age for when childhood ends and adulthood begins. 2017 collaborative protocols defined a pediatric as being children without secondary signs of puberty. In collaboration with the EMS for Children Committee, the pediatric definition was updated in the 2019 collaborative protocols to patients who have not yet reached their 15th birthday. For our pediatric patients, it is strongly recommended to use a length-based resuscitation tape or similar device, and weight-based medication should be calculated on a per kilogram basis, with the adult dose being the pediatric maximum. Incorporated into the 2019 collaboratives are the New York State BLS protocols for the general approach to the EMS call, the patient, use of safety restraint devices, and approach to transportation. These protocols provide a framework for all calls, and they put an emphasis on the safety of our providers and the safe transport of our patients. General approach to the patient. This is what we already do, and part of the integration of the New York State BLS protocols into the collaborative protocols. And it's important that we do a good assessment on all of our patients. Yes, even those who utilize our services frequently. The safety of our providers and patients during transport is of the utmost importance, and one of the biggest changes regarding this is how we transport pediatrics. It is no longer permissible or safe to have a child sit on the lap of a parent or caretaker. Please look at your agency policies, equipment, and approach to the transport of pediatrics and update as appropriate. So how do you do this? Not every ambulance has room to carry a car seat or comes with an integrated car seat. Well, Google can be your friend and can lead you in the right direction. Search out pediatric ambulance safety restraint. There are pediatric child restraint systems out there that will hook onto your stretcher quickly when needed and roll up and fit into a cabinet when not in use. They range from $111 up to $800 depending on the models. Annual training should occur on the safe transport of pediatric patients that focuses on your operational policies and equipment. I would also encourage each agency to appoint a pediatric emergency care coordinator. Reach out to your local program agency for more information regarding how to become a pediatric emergency care coordinator if you do not already have one. The general approach to transportation is another New York State BLS protocol that was incorporated into the collaboratives, and it is important to carefully consider the use of warning devices. Risk versus benefit is key, and there is a multitude of information out there that portrays the dangers with the utilization of lights and sirens. Safe emergency vehicle operation training should be incorporated into your annual training and your operating guidelines, focusing on good clinical judgment and decision-making regarding the use of lights and sirens. New to the 2019 collaborative protocols is a cardiac arrest general approach for pediatrics, and includes a reminder that our pediatric patients may be better served with an effective BLS airway. Paramedics must use good clinical judgment when deciding whether or not to intubate a pediatric patient. Under the cardiac arrest VFib or Pulseless Tach protocol, the dilution of amiodarone during cardiac arrest has been removed, and so has the medical control consideration for dual sequential defibrillation for persistent ventricular fibrillation. Respiratory arrest failure is another New York State basic protocol that has been incorporated into the collaboratives, and it includes patients who present with absent or ineffective breathing. This protocol incorporates all levels of care from CFR to paramedic, and also includes the signs of ineffective breathing. Under the respiratory arrest failure protocol, there are some additional key points and considerations added. Patients who present with respiratory arrest or failure need definitive care, and you should not delay transport. It is also important not to agitate a patient that may have a partial airway obstruction. Early notification to the emergency department will benefit your patient by giving the hospital the time to prepare, especially for our pediatric patients. Under the Termination of Resuscitation protocol, a new consideration has been added for critical care and paramedic providers. They should consider the ETCO2 when discussing termination of resuscitation with medical control. Over the last few years, the medical evidence has pointed toward the benefits of working a cardiac arrest patient on the scene, as effective or safe compressions cannot be accomplished in a moving ambulance. This has been a difficult change in practice for many, but the medical evidence points to the benefits. Please use good clinical judgment and your resources when you are considering termination of resuscitation on the scene. They must meet the criteria listed within the protocol, but even if they do, contacting medical control is not a bad idea. A new protocol for both BLS providers and ALS providers is a guideline when presented with a pediatric patient who has had an apparent life-threatening event or a brief resolved unexplained event. An example of this would be a call for a pediatric patient who is not breathing or turning blue from a seizure, and prior to your arrival the seizure stops and the patient presents with no life threats. This may be a sign of an underlying injury or illness and should be assessed and treated as appropriate. Also, transport of this patient is highly recommended for further medical evaluation. Under the adult anaphylaxis protocol, the CFR level was added and includes the criteria and dosage for epinephrine autoinjectors, if they are trained and equipped to give them. Indications are if the patient has severe respiratory distress, facial or oral edema, and or hypoperfusion, or if the patient has a history of anaphylaxis and has an exposure to an allergen developing respiratory distress, and or hypoperfusion and or rash. They may administer the adult epinephrine autoinjector 0.3 mg IM if the patient is greater than or equal to 30 kilograms, which is 66 pounds. If the patient does not improve within 5 minutes, they may repeat the epinephrine autoinjector once. EMTs may utilize the syringe epinephrine when appropriate instead of the auto-injectors if equipped and trained. The curriculum was updated in May of 2017, and all EMT courses are required to teach syringe epinephrine in the original and refresher classes. Epinephrine IM has been added to the AEMT level along with a 500 milliliter fluid bolus of normal saline. If the systolic BP is less than 100 or MAP less than 65, this was previously less than 90 and 60, respectively. Additional changes to the adult anaphylaxis protocol include that the critical care paramedic providers may utilize albuterol and ipratropium in place of albuterol alone. There are also additional key points considerations, such as IV epinephrine should not be administered without contacting medical control, and a reminder that anaphylaxis may develop in patients with no history. Also, the anaphylaxis may present with shock only with GI symptoms, and you should contact medical control if they have a known exposure, are presenting with GI symptoms only, and you clinically suspect it is anaphylaxis. The pediatric anaphylaxis protocol mirrors the changes that we discussed in the adult anaphylaxis protocol and includes the dose of the pediatric auto-injector, 0.15 milligrams IM if the patient is less than 30 kilograms or 66 pounds. There are infant auto-injectors available, and they may be substituted for pediatric patient less than 15 kilograms or 33 pounds if available. The criteria for this protocol are patients who providers suspect to have an exposure to carbon monoxide. If you have the ability to monitor carbon monoxide levels of your patients, it provides specific treatment guidelines based on those levels. All patients with suspected exposure to CO should receive high-flow O2. Also included is the consideration for the use of CPAP in symptomatic patients, and you should consider contacting medical control to discuss the appropriate hospital destination versus directly transporting to a hyperbaric center. It is important to make that contact to medical control for appropriate hospital destination when the patient presents with one or more of the following: SpCO reading of greater than 25%, loss of consciousness, they have a significant altered mental status or an abnormal neurologic exam, or they are pregnant. In the 2017 protocols, this was called acute coronary syndrome, suspected cardiac chest pain. There is criteria added to this protocol indicating the protocol is for patients presenting with suspected cardiac chest pain, angina, or an anginal equivalent. For the patient with a confirmed ST elevation MI, see ST elevation MI protocol as soon as you have confirmed it. Aspirin administration has been moved to the CFR level if they are equipped and trained. There is language surrounding confirmed ST elevation MI, medical control, and transport destination decision added. Acquisition of 12 leads by an EMT is a regional adjunct and must be transmitted to the hospital if acquired. Please consult with your regional policy regarding the ability for EMTs to acquire and transmit 12 leads. Nitroglycerin was moved to the AEMT level as it is within their scope of practice. And remember, the EMTs can only assist a patient with their own prescribed nitroglycerin. A frequently asked question since the release of the New York State BLS protocol update is the removal of having to ask a patient if they have taken an erectile dysfunction drug before administering nitroglycerin. This applies only to BLS providers as the patient is already prescribed the medication, they are only assisting, and the prescribing physician has already addressed the risks and benefits of the medication. AMT and above providers need to continue to ask this question prior to the administration of nitroglycerin. The cardiac-related problem for the pediatric patient is new to the collaborative protocol. Pediatric patients who have known heart disease and/or have been operated on for congenital heart disease have medical emergencies that are different from adults with heart disease. Pediatric patients with congenital heart disease may present with baseline oxygen saturations between 65 and 85%, rather than above 94%. Be sure to ask their care provider about the patient's usual oxygen saturation level. Pediatric patients with heart disease may develop sudden heart rhythm disturbances, be fed by either a nasogastric tube or by a G-tube. They may not have a pulse or an accurate blood pressure in extremity after heart surgery, or they may present with a pacemaker. The difficulty breathing, asthma, COPD, wheezing protocol for the adult patient is a combination of the 2017 asthma and COPD protocol for the adult. EMTs may administer albuterol via nebulizer if trained and equipped. For wheezing, it's no longer just limited to asthma. Move to the AEMT level is epinephrine 1 in 1,000, 0.3 milligram IM for severe distress. And if severe distress persists, they may repeat that in 5 minutes. They may also administer albuterol 2.5 milligrams in 3 milliliters via nebulizer or ET tube nebulizer, and they may repeat that to a total of 3 doses as necessary for continued wheezing. Under the difficulty breathing, asthma, COPD, wheezing protocol for the adult, it is appropriate for paramedics and critical care providers to substitute albuterol and ipratropium bromide for albuterol alone. As outlined in red, you can always contact medical control for additional albuterol doses or magnesium for the patient with a COPD exacerbation. Also included is the racemic epinephrine dose of 0.5 milliliters in 3 milliliters of normal saline via nebulizer. Under diff breathing, pulmonary edema, our critical care and paramedic providers' treatment of a patient in pulmonary edema includes dosing of nitroglycerin 0.4 milligrams sublingual or equivalent based on the patient's systolic BP. This has been added as a medical control option for the AEMT provider. Under the difficulty breathing, asthma for the pediatric patient, you will note that pediatric patients with asthma who are not responding to albuterol and are in severe distress, AEMT providers may contact medical control for the administration of epinephrine if clinically appropriate. This could be given via an auto-injector or by syringe epinephrine. Depending on the age of the patient, CPAP may be indicated if they are trained and equipped. New to the collaborative protocols is a protocol for fever. It includes general guidelines for the treatment of adults and children presenting with fever and introduces 2 new oral medications to the formulary, acetaminophen and ibuprofen. As of this time, both medications remain an option in the North Country and the Central New York region, but they are required in Midstate, Finger Lakes, and the Susquehanna regions. Please review a short presentation on ibuprofen and acetaminophen that is provided in the links that are included in the video description. Here is a snapshot of the adult fever protocol with the dosing for both acetaminophen and ibuprofen. Another important contraindication to consider for ibuprofen is pregnancy. Please do not administer ibuprofen to a patient who is pregnant. This is a snapshot of the pediatric dosing for acetaminophen and ibuprofen under the Pediatric Fever Protocol. This was updated at the September 2019 state EMS meetings, and patients should be greater than 60 days old to receive acetaminophen or greater than 6 months old to receive ibuprofen. This chart is updated from the collaborative protocol that is posted on the New York State DOH website and hopefully will be inserted into that document soon. Under the hypoglycemia protocol for pediatric patients, If the AEMT is unable to obtain adequate results with oral glucose, they can consider giving glucagon 0.5 mg IM if the patient is less than 20 kilograms. Otherwise, they can consider 1 mg IM if needed. To align with the national curriculum, the administration of naloxone, Narcan, has been moved to the AEMT level of care and above. CFR and EMT level providers who are equipped and trained may administer Narcan as well. Through chart review, we have seen multiple administrations of Narcan to patients who have not presented with hypoventilation. Despite the fact that Narcan is a fairly safe medication, it can have side effects and should not be given if not indicated. Also, please don't forget that you should be supporting their ventilations with a BVM, if indicated, prior to administering Narcan and until such a time that they have a return of effective breathing. The adult and pediatric organophosphate exposure protocols have been combined. Previously, some of the information was also found in the Pediatric Overdose Toxic Exposure Protocol. Under the paramedic level, they added a pediatric dose of atropine and removed the Versed dose. They also put in a referral to the seizure protocol. For symptomatic pediatric patients with an organophosphate poisoning, paramedic may administer atropine 1 mg IV every 3 to 5 minutes until secretions dry. And again, if needed, please refer to the appropriate seizure protocol. Under the adult pain management protocol, acetaminophen and ibuprofen have been added under the AEMT level. And ketorolac, Toradol, has been moved from a medical control option to one of the critical care and paramedic choices for pain management as a standing order. They now have a choice between one of the following: morphine, fentanyl, and ketorolac, and should choose the one that is most appropriate for the patient's clinical presentation. Also, please note that the dose of ketorolac has been decreased to 15 milligrams IV or 30 milligrams IM, as the literature is showing that it is just as effective at lower doses. Another key point consideration is that you may only choose one non-oral pain medication under standing orders, and for dosing that exceeds the standing order maximum, or to switch to another agent, you must consult medical control. Ketorolac, Toradol, will become a required medication in the North Country and is currently required in the Central New York, Midstate, Finger Lakes, and Susquehanna regions. Under the pediatric pain management protocol is the addition of nitrous oxide by self-administered inhalation to the AEMT level, and if the patient is able to tolerate oral fluids, they can consider giving one of the following: acetaminophen 15 milligrams a kilogram PO, or ibuprofen 10 milligrams a kilogram PO. There are weight-based dosing charts in the protocol for both medications, and please note that acetaminophen should not be given to a pediatric patient younger than 60 days, and ibuprofen should not be given to a patient less than 6 months old. Also, just a reminder that nitrous oxide is not a required formulary item, and it does require specific REMAC approval and education to administer and carry. It also includes contraindications to nitrous oxide. Criteria was added to the shock hypoperfusion protocol for pediatrics to include sepsis. If your patient presents with the signs and symptoms of sepsis, shock, hypoperfusion, please make sure you notify the receiving hospital as soon as possible so that they can prepare to treat the child aggressively. Here is a snapshot of the sepsis, shock, hypoperfusion protocol for pediatrics. With blood pressures being very difficult to obtain in infants, It's extremely important to assure that the respiratory rate and the pulse rate are measured accurately. Also, again, communication with the destination hospital is critical so that they can prepare to treat that child aggressively. Another addition to the sepsis, shock, hypoperfusion protocol for pediatrics is under key points considerations. You will find vital signs criteria to assist you in defining sepsis for multiple age ranges. Under the general stroke protocol, which applies to both adult and pediatric patients, please note the time change to 3.5 hours from 5 hours when considering the destination for your stroke patient. The time from last known well, or time of symptom onset, to estimated arrival in the ED will be less than 3.5 hours. Transport the patient to a New York State DOH designated stroke center or consult medical control to discuss an appropriate destination facility unless otherwise regionally designated. Also, it's important to make sure to record the last known well and who reported that information as part of your verbal report at the hospital and in your written documentation. This is another instance where you should be notifying the hospital as soon as possible. Technology-assisted children is new to the collaboratives and originates from the New York State BLS protocols. More and more, we are finding both adults and children being cared for at home that require technological assistance for life support, such as a ventilator or a tracheostomy. This protocol lists some of the more common medical interventions that you may find when you are called to care for a child with special health care needs. Caregivers may be your best support as they are well trained on their child's special health care needs, and please do not hesitate to contact medical control if you need additional guidance. Notifying the destination hospital that you have a child coming in with special health care needs and being very specific about what the child has and will need will assist the incoming hospital to prepare for the child. It is also important to take necessary specialized equipment, for example, the patient's trach ventilator pack, G-tube connectors, etc., to the hospital with the patient if possible. This is a new protocol in the 2019 collaborative, and as medicine advances, you may see patients that have a total artificial heart being cared for at home. This is different from a left ventricular assist device. It is important to notify the receiving hospital early of this, regardless of the patient complaint, so they can be prepared. Assure that the patient has both drivers, hand pump, all batteries, and power cords for transport, and if possible, any trained support member should remain with the patient. A patient with a total artificial heart has had their heart removed and replaced with a rigid device which pneumatically pumps blood throughout the body. As these patients do not have a heart, there is no indication for an ECG or cardiac monitoring. The patients will be on multi-agent anticoagulation, and they may have significant bleeding with minor injuries. The total artificial heart patient has a normal pulse and blood pressure detectable by conventional methods. They are highly preload and afterload sensitive. Their target blood pressure should be less than 150 millimeters of mercury or greater than 90 millimeters of mercury. If the blood pressure is greater than 150 millimeters of mercury, administer sublingual nitroglycerin 0.4 milligrams at the advanced CC and paramedic level. This may be repeated every 5 minutes if their BP remains greater than 150 millimeters of mercury. Make sure to assess for hypovolemia, and if their blood pressure is less than 90 millimeters of mercury, or they have evidence of distributive shock, blood loss, or dehydration, they will need to receive a 250 milliliter fluid bolus. This may be repeated up to 1 liter if hypotension persists. Again, they can then contact medical control for any additional fluids beyond 1 liter. Do not apply a cardiac monitor or perform pacing or defibrillation, and do not administer vasopressors or antiarrhythmics. Under the bleeding hemorrhage control protocol, you will find junctional tourniquets listed. These are regional options and are required in the Central New York region, but remain optional in Midstate, Susquehanna, North Country, and the Finger Lakes region. Junctional tourniquets are commonly used in the military and by tactical EMS teams. In the burn protocol, you will find a bullet for the treatment of eye exposures that was moved from the 2017 eye injury and exposure protocol. Tetracaine and Morgan lenses are a regional option and remain optional in the North Country, Central New York, Midstate, and Susquehanna region, but are required in the Finger Lakes region. Bilateral needle chest decompression is not in the national curriculum for the AEMT. There are some specialized tactical teams who train their advanced EMTs in this, but the agency must be approved by the REMAC to do it. Please note that the asterisk means that you must be approved by the REMAC and have additional education and training to do bilateral needle chest decompressions at the AEMT level. Congratulations, you have completed the 2019 Collaborative Protocol Update video. Be sure to watch the brief video on Motrin and Tylenol in the playlist, and please go into the online CME system and take the 2019 Collaborative Protocol Update quiz for your respective level of care. The quiz needs to be completed by December 31st, 2019. It is recommended that you take the time to review all the 2019 protocol changes, as the CFR level and wording changes were incorporated into all of them, and we only have elaborated on the most prominent changes. In the YouTube description for this video, you will find a link to a protocol comparison document that outlines changes, some of which were not covered in this video. A playlist has been created with some of the 2017 educational videos for your convenience. Thank you, and if you have any questions, please reach out to your regional program agency director.